So let me kick off this semester's Global Public Health Seminar Series by introducing our speaker. We're very fortunate today to have Alexis Wolf come down from Helena, where she is the Training and Development Specialist with the Montana Department of Public Health and Human Services. I've had the great opportunity to meet Alexis today. I think you're going to find her work both in Helena and her work overseas of interest, and so she really connects the global and the local in a lot of ways. So she's going to be talking today about new directions in public health, reflections from a workforce development perspective. So please join me in welcoming Alexis Wolf to our Global Public Health Seminar Series.
Thanks, guys. I'm happy to be here. It's nice to get away from Helena for a bit and be in the big city. So before I get into the nitty-gritty, I just wanted to give you guys a little bit of a background on myself, kind of where I've come from, my career so far. So I started my sort of academic career in St. Louis, Missouri, where I'm from, at Webster University. Started out as an international relations major. There I studied abroad in Thailand. It was a requirement for the program to study abroad for a semester. And while over there, I just absolutely fell in love with the place. So after I finished my bachelor's degree in IR, I decided to pursue work and continue on with my education and obtaining a master's. So while in Thailand, I worked for a small nonprofit called Asylum Access, where it's kind of where I got I kickstarted my training and workforce development career. For Asylum Access, I did capacity building for incoming refugees and stateless people. So what was really cool about that is I got to work with them on sort of economic empowerment and what you can do in sort of a difficult situation where you have no rights by law, but you have a family, you have kids, you have needs that have to be met. So we did a lot of training and capacity building around those things. And so that sort of, kick-started my interest and passion for capacity building. And from there, I focused my graduate program and studies on capacity building and refugee studies and sort of the intersection between them. And so in each of my classes, I applied those adult education principles and practices to my coursework and tried to tie it all together. So from there, I graduated in 2015 with my master's, and I decided to come back to the States and work in DC, where, as you know, it's the hub for international development in the U.S. I worked for World Vision for a time in their Humanitarian and Emergency Affairs Department. There I worked again on professional development and capacity building. I think the coolest part about my job, before kind of getting into what I do now and what I do on a domestic perspective, the cool thing about workforce development and training is that I get to support people like you, people who are working professionals in the field, to be the best at their jobs so that they can deliver services effectively and quality services at that. So it's definitely a passion of mine, because what we do see a lot in our arena is sort of a lack of these technical skills that are required to implement and develop programs. So that's just a little bit about me in my international sort of work that I've done. In 2017, I did decide to move to Montana, and that was a very calculated decision. I had been doing work after World Vision with a international development, or I guess to get more specific, they were an engineering firm that had a small unit that did capacity building for foreign governments. Well, that was really awesome and interesting. I was struggling, I think, to find my place there because I just didn't see that immediate impact that I think in this field we all kind of crave, you know. So, had a really great friend who was working out here in Montana for CDC say, hey, what do you think about Montana? If I found a job out here, what did you think about that? I'm like, I consider it. So here, 2 weeks later, I get an email, and here I am. And here we are. And it's actually, you know, when I looked at the job description and what would be required, I thought this is exactly what I want because it's going to be extremely challenging, limited capacity, so much responsibility, lots of stakeholders, lots of people involved. But again, I wanted to get back to my roots of like, I wanted to be able to be with the people that I knew I would, you know, that were making a direct impact and that I could see it around me in my community. So that's sort of how I got my start and why I'm here today. And so, you know, over that period of time, I've developed my own skills around workforce development and then in public health. It's not really, you know, I don't have a formal background in public health, and we'll talk a little bit about that later, but it's just been a great journey, and I hope to share some really interesting things with you all as you sort of transition into into your own careers and into your new paths. So just a quick agenda. You know, to understand the topic that, you know, that Peter mentioned, which is the future of public health workforce, we first have to understand what workforce development is, what public health systems are, what the public health workforce looks like, and then talk a little bit again about workforce development in public health and that intersection. So all of those things are definitely needed at a basic level to understand like where we're moving. And I hope then by the end of things you'll have some solid takeaways as, like I said, as you transition into your careers. So, all right, big question here. As a trainer, I do want to engage you guys. So I have a question, which is, what is workforce development? Can anybody answer that? Does anybody have an idea about what it is? Anyone?
Like training with people on the ground actually doing the stuff.
Great. Okay.
And recruitment.
Yeah, exactly. So it definitely has to do with recruitment. It definitely has to do with retention. And you know, this is a question that, you know, is multifaceted and has many answers. So I threw up a couple definitions here. The first is it's in general the continual process used to align the needs and priorities of an organization with those of its workforce, and that's to ensure that it can meet its own organizational requirements and objectives. Okay, so that's in general. In public health, and this is according to the Public Health Foundation, workforce development is defined as an attempt to improve health outcomes, i.e. healthier people, by enhancing the training, skills, and performance of the public health workforce. So you can definitely see the crossover. And you know, in addition to these definitions, it can look immensely different from organization to organization, and organizations can define it differently, and it can play out differently. It's also called workforce planning. You've probably heard professional development, training and development. These are all sort of the same thing, and there is definitely a general consensus. I would say the first definition is sort of a broad, all-encompassing definition. So that's what it is. I will say, you know, we'll get into a little bit more detail about sort of how that might play out. The definition you provided, you know, this comes into play with certificate programs, with trainings and workshops, with continuing ed programs like those that we support at the university. I mean, there's so many ways that workforce development sort of plays out. So we'll talk about that a little bit more. So I just wanted to touch on briefly what the workforce development or planning cycle looks like in practice. And this can actually be applicable to a macro and a micro scale. I'll give you the macro long version, I'll give you the micro short version as an example. But so at the assess, you start out the workforce planning cycle by assessing agency and organization needs to understand what talent already exists, right? And then we sort of look at how that aligns with our organization's priorities or mission or vision or values. And this is inclusive of workforce competency and workloads. Then once you assess, or an example would be a project we're doing is a statewide public health workforce assessment, right? So we send out a survey to all of the public health workers in the state, in every local, tribal, and state health department. So after that, we go to analyze. We collect the data, and we compare the supply and demand to identify what gaps exist. And that is, the gap analysis incorporates both those organizational priorities and those that are important to the workforce. And then you're going to compare and contrast those and prioritize those. That's where the planning comes into play. You either develop a plan, so it could be a comprehensive, like the example I gave with sending out this survey to the entire workforce. We then develop a comprehensive workforce development plan, and that would have strategies for minimizing or closing those gaps. Then it comes to the implementation phase. That's where we actually implement the plan. And so we say, well, based on our workforce assessment, we've identified these 5 priorities. We know that that staff need training or education around evidence-based practice. And that's an organizational priority too, so that's number 1. And we're going to then pair that with either an educational program, a training, a workshop, a retreat, something like that. I mean, and it could even be an online program. Once we do that, and we've implemented that plan, we then evaluate it to see how effective our plan was, and if we missed anything, or if we need to refocus, or maybe change a few things. So that could be done through a comprehensive evaluation. So we could revert right back to that big assessment, or we could even do individual focus groups, survey, interviews, things like that. So the example I mentioned was a macro, like a large-scale sort of workforce development project. But like I said, you could sort of boil that down to the micro level, and even just based on one training, one coach, one could be coaching, things like that, where you identify an individual's need. So I would ask you, hey, what do you need to be more successful at your job? And we could work on a plan together and evaluate that together. So it can definitely be applied to many different scenarios. That wasn't, you weren't supposed to see that. So another question, based on what I just told you, what do you think some of the benefits of workforce development or workforce planning are?
You can make sure that people don't burn out quickly. You can make sure that their needs are being met as your employee, that they can optimize your efficiency in any given stage, and then you're also having a dialogue between people that are working on the ground and people that are higher up within whatever that structure is to make sure that those goals are in alignment.
Absolutely, you're spot on. All of those are great examples. So I just threw up a bunch here, but the list goes on. I mean, a couple you mentioned, leadership awareness. That's a big one. I mean, you see that in a lot in organizations where there's just so much disconnect. There's so much space in between the entry-level employee and the senior leadership team. So that's really important. Recruitment and retention, that was mentioned earlier. Capability and capacity. We have, capacity is a huge problem at the local level because we have limited resources, limited staff, limited funding. So then it takes us to this budgetary support, right? This gives us a rationale and justification for then pursuing some of these programs and promoting them, and it gives it some importance. So another question, what do you think, for public health specifically, why do you think workforce development is important or is so important? So these are sort of the general. But for public health, what do you think? Ideas? Okay, I'll give you the answer. I'll make it easy this time. So we go back to this definition here, right? An attempt to improve health outcomes. That is our ultimate goal and mission in public health, right? So what I said earlier, I mean, why I love my job so much is because I can indirectly sort of impact those health outcomes by supporting people like you, professionals in the workforce. They're then more effective at their jobs. They then have, it's sort of, in another way, it's invigorating, it's reinvigorating for people who have been in public health for so long. Training isn't just for people who are entering the workforce. I mean, this is for people who have been around for 30 years, and things change. Lots of things change. So, yes, strategic alignment. I mean, that strategies change over time based on trends. Huge thing we focus on, too, in the health department is skills gap identification based on public health core competencies. And we'll talk a little bit about the public health core competencies, but is anybody familiar with those? What about the 10 essential public health services?
They better be familiar with those because Haley gave a lecture on that earlier this semester. So.
Well, you did.
This is the very beginning of the semester.
Well, we'll kind of talk about it a little bit more. But so any questions so far before I kind of move on into the public health system? Okay. So that's just kind of workforce development in general, and then just,
Actually, I had a question.
Yeah.
So you said that you were at the stage, I guess, of the statewide workforce assessment survey. What have you found out so far? Do you have any?
So I don't have, okay, a couple answers. We've done crosswalk analyses of the various workforce assessments done by, and I'll get into this a little bit later, but we've done crosswalk analyses of the different local assessments and then assessments done by us and then the various public health associations in the state. But because we're decentralized, we've never done anything like this before. And we're actually still in the process of developing the survey. So more to come on that. But overall, what we see as far as what's come out of the crosswalk analyses is that there's about 4 main priority areas: program planning and evaluation is a big one, community health improvement planning, and that's kind of part of that program planning and evaluation. There's also quality improvement and performance management. Those are big and recently emerging trends in public health. We know from our state health improvement plan that behavioral health and training around behavioral health and public health is a huge need because we're seeing more and more, especially in our state, that this is an issue that oftentimes people don't have any other resource except for the health department to go to for things like this. So we're trying to figure out how to navigate these things and be able to support our public health employees with these competency gaps. But yeah, I will happily fill you in on the details once we get the actual results come fall. Okay. So, public health systems. I'm sure you guys are all familiar with these, but I wanted to ask another question. I'm all about questions here. What is public health to you guys? How do you define public health? Because this definitely plays into public health systems and what they are.
I think that public health encompasses a whole wide variety of how people walk through life, whether that's accessibility to different kinds of healthcare, or accessibility to open public space, or to education and information and about leading a healthy lifestyle, and trying to make sure that people who need extra assistance can access that assistance with needs and support.
Perfect. So, based on your answer, right? Public health is extremely complex. There are so many different intersections, so many different players involved, and it has to be because of there are multiple things that impact health, not just our physical health and our genetic makeup. The social determinants of health. We know that our economic background affects us. Our educational background impacts our health. So what do you think, based on that definition, a public health system is comprised of? Is it just one thing or one entity? No? All right, good answers. You are spot on. So isn't this crazy? Look at this. This is wild. That is an example of a public health system. Look at all the crossovers there. So the CDC defines a public health system as all public, private, and voluntary entities that contribute to the delivery of essential public health services within a jurisdiction. So this can be, like you mentioned, there's education and youth development organizations involved, not just the health department. There are charity organizations, environmental agencies and organizations. So it's not just healthcare. It's not just public health. There are all of these different people and players involved. So let's kind of talk about what this means globally and then boil it down to the local level. So can anybody provide me some examples maybe of who they think or what entities are a part of the global public health system?
World Health Organization, Doctors Without Borders, United Medical Aid, anything that starts with that, and then a whole variety of NGOs, also government organizations, whether that's Peace Corps or other government sponsored, like peacekeeping missions probably would be under healthcare as well.
Absolutely. All of these. What about nationally? Yep. CDC, we've got the Public Health Foundation, different associations like the American Public Health Association, Association for State and Territorial Health Officials. The list goes on, right?
And I think the important thing about looking at global public health nationally is looking at what national governments in other countries do too. So there you're looking at mainly, of course, the ministries of public health, but there are other ministries that relate to health too, just like that complex intersecting diagram that Alexis showed you.
Exactly, and it's just, it's very similar on a national level here, very similar to other countries, like Peter said, where they have centers for disease control, just like we do, and so on and so forth. At a state level, I won't ask you guys this, I'll just give you the answers here. We have the Department of Public Health and Human Services, tribal health departments, various associations like the Montana Public Health Association, Association for Montana Public Health Officials, healthcare providers, law enforcement, environmental organizations, so on and so on and so on, right? So we've slowly kind of learned over time that public health really does take a village. It really does take partnership. It really does take dedication from many, many different sources. And this is because public health is comprised of these cross-cutting areas, like I mentioned before, the social determinants of health. So when you factor in the delivery of the 10 essential services and all of that, it can be really, really difficult to do. Especially here in Montana, where our health departments operate with limited capacity and funding. We're a decentralized public health system, which I'll talk a little bit about later, but that basically means that we do not have at the state level authority over the local and tribal health departments. Okay?
And one of the consequences of this, both domestically here in Montana and internationally, is because there's so many different actors involved. We haven't mentioned private companies like Big Farm and tobacco companies that have an impact on health as well. Because of all these different actors being involved at different levels too, there is a really serious problem of coordination. There's a lack of coordination that goes on in terms of the public health system.
Yes, that's a great point. And I think communication is definitely part of that. And so I think, to tie it back to kind of what I do here, it's a huge effort, but it has to really be done in order to make the significant progress and change that we want. So speaking of that, let's talk about the public health system in Montana. Do you have a question?
Yeah. I was wondering if you were including law enforcement in your survey as an assessment as far as the public health today, or if you're just focusing mostly on providers.
So we're not even focusing on providers for the assessment. We are focusing solely on public health workers in the health departments. And so there are, I'll talk a bit about this in a little while, but there are core competencies that, have been decided on at a national level and standardized that any public health worker in the workforce should have or should meet, right? So that's what we're looking at. Not necessarily the entire system, because that would just be, wild. But, we're really trying to hone in on our actual health workers and those at the health departments. Great question, thank you. So Montana is decentralized, as I mentioned before. And what that means really is that, like I said, we're very segmented. We're very siloed. The legislature does not have authority over all of the health departments in the state. The state health department is governed by the legislature. Local and county health departments are governed by local boards of health. And has anybody had any experience or has anyone heard anything about local boards of health? Sort of what that, all right, great. Well, so what that means basically is that, so these local boards of health are appointed by typically like a county commission. These may not be people that know public health. These may not be people that have ever been involved in public health. But they're making decisions. So that's one thing, one consideration, one thing we've got to keep in mind, sort of when looking at the dynamics and and how we can influence workforce development. Tribal health departments are governed by tribal councils independently. And so all of our health departments throughout the state vary widely in size, in infrastructure, and capability, and staff power. I mean, it ranges from hundreds to 2, or 1 even at times. And then, of course, part of our public health system, like we had talked about before, all these associations, law enforcement, so on and so forth, and they have a direct influence on public health in the state and the directions that we move in. Okay, so getting into my favorite stuff here, the data. We're going to look at public health workforce as it stands globally, domestically, at a national level and then at the state and local level. So based on World Health Organization reporting, hasn't been done in a while, but in 2013, they reported that there were 34.5 skilled health professionals per 10,000 people globally. Approximately 7.2 million midwives, nurses, and physicians were needed at that time. And that was expected to increase to over 12.9 million. So I'm sure we're about there. We knew that, 83 countries were facing a health worker crisis. There were just not enough of us to go around. And the other thing that came out of this report that was really interesting to me was that on a global level, we're very, in public health, we're very doctor dependent and disease focused. So with the new Sustainable Development Goals, they've sort of they've looked at this and said, okay, so we're still missing something. We've got, like I said, there's this demand that we can't meet at, a level of healthcare providers, but also we need people to be on the ground implementing these programs that are sustainable, that continue on past when this doctor leaves, right, or if they do. So, yeah.
Question. I was just wondering what you think the implications or the consequences are of us having this doctor-dependent and disease-focused system.
That's a great question. Well, I think, the sustainability factor, right? Because we're just putting Band-Aids on things, and we're not really addressing the underlying root causes. We need community-based change and awareness and understanding on these things. So that's where the public health worker, your average public health worker, your health educator comes in, to think outside of the box so that we are able to prevent some of these diseases, so that we don't have this cycle just going on over and over again. The other interesting thing about when I was doing some research for you guys on this, there's not a lot of data on demographics or competency gaps. There's just data on numbers. And that's partially because of this, as Peter mentioned, this system at a global level is so massive, and it's difficult for us to collaborate with all these players. But I know that the World Health Organization and through the Sustainable Development Goals with the UN, they're doing a lot of work around this to increase health financing and the recruitment, development, training, and retention of the health workforce in developing countries specifically. So they're doing some work on this. They're trying to figure out, all right, so how can we manage this? What can we do? Like, this is so overwhelming. So there's, a couple different things have happened since then. And I'm sure you all are familiar with the Global Health Corps. No? Yes? So they're basically like Peace Corps. And so, there are efforts around things like that where they're bringing in not just doctors, not just clinicians, but actual public health workers, health educators, to serve in these positions for a couple years to try and eliminate some of these gaps.
How does it affect this backslide and this nation-first mentality that seems to be on the rise in the U.S. America first, Hungary first, Poland? How does that really affect the world, the WHO's goals in trying to implement some of those policies and get the funding?
Oh, Yes, yeah. I mean, it's just a severe negative. It's taking us back in terms of the progress that we've made. I mean, it's really, you're right. You're completely right. It's impeding our progress.
Do you think it's more important to focus on political change than it is to focus on this, which areas may be most important to focus on?
I think we have to do it simultaneously, honestly. It can't just happen. There can't be this hierarchical nature or succession to it. It has to happen in sequence because, otherwise we are going to continue to backslide. And with the social determinants of health being such an important topic and an area where we're kind of moving as in public health. I mean, that has to be recognized, and so yeah, and incorporated into this, this health, health equity and health and I'm trying to think of exactly the words, health in all policies. That's what I'm trying to say. So yeah, I don't think they can happen separate. I think it has to happen, at the sort of same time.
I haven't heard much about what funding is available for global scale public health work. I guess, we have the nation first philosophy and we want to take care of our people first kind of a thing. How would you address that at a financial level? How would you provide funding for that? Sorry, my question.
No, that's okay. Yeah. It's pretty darn complicated because, funding for these massive, global scale efforts often come from private sources. Just as an example, when I worked for World Vision and their humanitarian emergency affairs team, millions of dollars came from private sources. So I think where we can see initiatives really, take off are in those instances where we do get private funding because they're really, really passionate about a specific issue and they're willing to dump all of their money into it. In addition to that, we do see a lot of federal grant funding being sourced elsewhere. CDC has a presence globally, and it's so I think the funding is definitely there and it's being sourced, but it's just, I guess the funding to sort of the issue ratio is constantly teetering. As you know, we're a country that's in debt, and we're constantly trying to sort that out. So I think where I've seen sort of some of the most impact is in where you do have those private funding sources. Like here in Montana, we have what's called the Montana Healthcare Foundation, and we get a lot of funding from them at the state level and at the local level. So I think it's sort of, thinking creatively and using and leveraging and Peter and I were talking about this earlier, but, in public health and in the public sector in general, we're always, we've got a dollar that we've got to do 10 things with. And so it's really just thinking outside of the box and leveraging what you do have, and collaboration. Collaboration is huge.
I guess what I keep struggling with is I want to have an answer for somebody who says to me, why do you want to take care of people globally when we're not taking care of our veterans here at home? And it's like, to me that's a valid question, but it's also, it's an answerable question. I would like to come back at somebody, well, this is how you could do both.
So I guess my answer to that would be it's a trickle-down effect. Like, if we are able to make positive change on an international scale, that's going to influence the priorities, it's going to influence the direction of many of the governments who are within that sphere. I know the U.S. right now, we're struggling a bit, and I don't have all the, I don't have the answers for that. But that's a complicated thing in of itself. But I think, it's setting precedents. It's and there are, aside from the U.S., of course, that at the global level, things that happen in the UN or WHO, those directly, that trickles down. So I would say, that's something that you can use to defend your decision. But yeah, I think, ultimately it changes the sort of culture and the climate and everything. If we're able to achieve some of those things on a global scale, that's going to directly influence our policies here. So.
Well, let me butt in here a little bit because I've got a number of things that I'm inspired to say by what Alexis was talking about and by your question, Alicia. So in terms of your question, I think you're right. It's not an either-or proposition, right? So the issue basically is we need to do more both domestically and internationally in terms of improving the health of people around the world. So, and we spend a lot of time talking about things like the Affordable Care Act and how we can do better here in the United States, and that's all important, and we should continue those discussions, and we should continue to try to find ways to do better, both domestically, including with veterans. That doesn't mean we should ignore, though, the problems that people around the world are having, because in many cases those problems are even much more severe, much more extensive, in terms of the number of people who are not getting access to even rudimentary kinds of health care. So if we turn a blind eye towards people abroad, it's reflective of our own ability to empathize and sympathize and to contribute from a position of greater wealth and capacity. So we have capacity to help, and we shouldn't let that capacity lie idle. Now let me get back to this whole issue of funding. So we know that the World Health Organization is grossly underfunded. And I've talked to you about this already in terms of the lack of resources that we give to the World Health Organization. And so most of the funding today, as Alexis pointed out, in global health and international funding, and don't forget there's a lot of funding that comes from national governments themselves, although they are often criticized for not putting as much money into health as they should. But most of the funding comes from large foundations. And I've given you some readings about that, like the Gates people, for example, all right? So they provide a lot more funding, and we have a lot more resources at their disposal than the World Bank and the World Health Organization do in terms of health.
And,
The problem is that a lot of this foundation and private aid is what we call vertical aid. It's vertically centered on one particular disease or one particular approach. Like in the Gates approach, they put a lot of emphasis on vaccination, but not much emphasis on the social determinants of health. So because you've got this tunnel vision, this single silo kind of approach, oftentimes the basic healthcare system gets ignored. And there's not a lot of interest on the part of these funders who are trying to show that they've made a big difference, because now 90% of the population get vaccinated instead of 60%. That's a lot easier to show than to show that you've made a difference in terms of basic healthcare access in a rural village somewhere. You do find NGOs that work in that area, but they tend to be much smaller in terms of scale. So one of the problems is we've got this great effort, but it's too single element focused. As Alexis has pointed out, this is a multi-dimensional problem. So that's why I wanted to chip in.
Thank you. Yeah.
Then I've got a question for you of that thing. Having worked in this area and then accepted money from sort of these foundations and private donors, how often in Montana do you feel like that money is tied to a particular project and it's inflexible? And so you have to use that as like a particular thing that they have this myopic focus.
Yeah.
And have you, in your experience, been able to sort of like convince people like, oh, well, maybe if we did this way instead, this could have a larger impact or whatever?
Yeah.
Part of what you do.
Yes. So, I think at the Montana Healthcare Foundation, they definitely do have directives. They definitely do have these sort of priority areas, and that changes over the years. I think here in the state, they've been pretty, they're very research focused as well. So they're very aware of what our issues nationally are, and then at a state level, and they take into account our state health assessment and the data that comes from that on our population health and what the main issues are, so that they can, really we can leverage that dollar and make the greatest impact. I think I'm not exactly sure, about other states or other foundations, but I do know that they here in Montana, they're pretty darn flexible. Like they will they have their priority area, but most of the time that aligns with our priorities as well. And then when it comes down to actually granting the funding, they do give a lot of flexibility, and they work with you a lot. So I think it really depends on the source. Here, I haven't had, I've had pretty great experiences working with them so far on a couple of projects, and I do see that the influence of their board or their funders or whoever's contributing, but I don't see, it is sort of an obstacle in and of itself to have to apply for a grant and manage one, but we wouldn't be able to do a lot of the stuff that we do without them. So, catch-22. All right. Yeah. Okay. So I don't know how much time I have. Sorry, I'm going over a little bit.
10 more minutes.
All right. So I'll speed through this. But at a national level, we know pretty well our workforce pretty well, I guess. Based on some national surveys that we've done, and the Public Health WINS, or the Workforce Interest and Needs Survey that we've done, it's the most recent, we know that our workforce is predominantly female, white, and over the age of 40. A third of the workforce has been in public health for 5 years or less. Most are college educated, but this is where my focus is. Only 14% of those surveyed have a formal background or education in public health. So I'll skip through some of this stuff, but the other important thing to note here, more than 1 in 4 public health workers who were surveyed intended to leave their job within a year, mostly due to pay, lack of opportunities for advancement, and work environment, right? But we do see these top training needs here, and that sort of factors into these lack of opportunities and work environment. And I threw these up here. We'll talk a little bit about them, but a little later on. But just so you can see kind of the crossover and the similarities between what we see at a national level and then at a local level. So this survey, if you're interested, check it out. The ASTO and De Beaumont Foundation did this, and they're starting to do it yearly. And this is, they got last year over 47,000 responses, which is pretty darn cool. So anyway, getting back to Montana, we've already talked quite a bit about Montana, but again, you see this sort of similarities here. Predominantly female, white, and over the age of 40. 50% of the workforce has been in public health for 5 years or less. Same statistic here, only 14% of our workforce in the state has a degree in public health. Here we've got reasons for leaving. Job satisfaction is one of them. Training sort of, falls within that. And then you see, again, these similar training needs across the board, from national to state and local. So I did kind of want to mention, too, the workforce, and I already mentioned the assessment that we're doing, but and that's because we have variable and limited data on demographics at the local level. So we know statewide these are kind of the training needs, but we really want to isolate it and boil it down to the local level, because we do know that, based on response rate, that we don't quite know our workforce statewide as well as we think we do, and their training needs. Okay, got to buzz through this. Public health workforce development. So who is working on workforce development? We've talked about these guys. We've talked about the players here. World Health Organization, UN, governments at national level, CDC, ASTO, public health institutes and training centers, especially, because they're, that is within their mission. And then at a state level, we've got a statewide workforce development group who's comprised of the different local, some local representatives, some from the state, some from the associations. So you kind of see the same players, like those involved in public health are very aware of what's going on with their workforce, or at least they're trying to be. and build awareness around it. So we see a lot of work being done in the last 20 years around assessments and surveys and studies of the workforce and strategic workforce plans to get a feel for how do we recruit and retain these workers, these talented workers, and what can we do? Retain. What can we do to keep them on? So kind of like I was talking about earlier, so we have the Council on Linkage's core competencies for public health professionals. This, all of the workforce assessment and planning that's done in public health is around these core competencies for public health professionals. So there was some consensus building around, okay, what do we think public health needs to know? We pulled in academics, we pulled in practitioners, so on and so forth, and we came up with these core competencies. So we assessed our workforce based on those and how well they do their jobs in those areas. Okay, so I already kind of talked about the workforce assessment that we're planning. So I just wanted to touch on the intersection between workforce development activities. So at an international level, it's a bit different because it's addressing everyone in the workforce, and that's a bit of a challenge. But at a national, state, and local level, like I mentioned, you see these overlapping and similar competency gaps around program planning and evaluation, evidence-based practice, budget and financial management, and then there are these new emerging trends that we're seeing in public health that are now impacting and influencing how we develop our workforce. And so you see this crossover too between, and as I mentioned before, consensus around how do we do it? Well, there are educational programs and certifications and trainings, and we involve universities, public health associations, regional training centers, and health departments, all of these experts in the field to figure out how to best address these gaps and approach these issues. The other thing, to mention is that there are a variety of different ways to deliver content and minimize these gaps. I mean, workforce development isn't just sitting down in a training and listening to a lecture. I mean, this can be online, it could be asynchronous or synchronous learning, it could be blended where it's in class and online. So there's many different ways that we can eliminate these gaps and support our workforce. So coming to conclusion here. So what am I getting at with all of this information, and where do you fit into this? All right. My final question, I promise. So who sets the direction of public health?
The people who take initiatives within the workforce.
Okay. Any other ideas? This is kind of a trick question. Ultimately, it's the public. Ultimately, it is what the public needs, right? Because we base the core competencies on what the needs of the public are. So they're the driver. And then, in addition to that, extensive research and studies, as I mentioned. So emerging trends, I wanted to talk a little bit about that because that definitely impacts sort of where you're going. And we're seeing this a lot in our assessments and our research and in our assessments not only of the workforce but of the public. So we see Public Health 3.0. Is anybody, raise a hand, anybody familiar with Public Health 3.0? Check it out. So we're moving towards these new models. Public Health 3.0 integrates this idea of a community health strategist, someone who's sort of this culminator of resources and people, getting everybody talking the same language and on the same page, and sort of how to do that, how to have these conversations with people outside of public health, but in the system. We see culture of quality because we've done the same thing over and over for so many years, and we're saying to ourselves, well, we haven't seen much progress here, right? So we're looking at quality improvement and how to internally within our organizations develop this culture of quality to influence our strategies and decision making. Some of these other ones that I mentioned already, but health in all policies, that's a big one. That's one that really is we're trying to push as a state, and that means social determinants of health. When Department of Justice is developing their programs, considering health, right? And multi-sectoral collaboration kind of comes into these things that we've talked about with just working with others in the community who have an impact on health. I also wanted to just mention, millennials in the workforce, right? So what do you guys, I'm part of millennial generation. What do we look for when we're looking for a job?
Benefits.
Okay. Great examples. And so part of the benefits, and I think there's been extensive research around millennial generation entering the workforce. Guess what the number one benefit that millennials request or are looking for? It's training and workforce development. So it's continued learning. It's not, we're very passionate about what we do, right? And so we want to stay on top of our game, and we want to know everything there is to know. So that's where this comes in. And I thought, I think that's really important as we kind of move forward from a state standpoint.
I've got a question about the health and all policies area. Are there people in the health department that actively work with legislators?
Yes.
And then are they is it like a lobbying sort of thing, where they get to go and be like, hey, add this thing?
So we are not allowed to lobby, but we do have all of the public health associations in the state do lobby. So we sort of wiggle our way around it, and then we have experts go in, we're in legislative session now. We have experts from our health department and from the local health departments go in and testify on behalf. So we're allowed to do that. We're not allowed to lobby, but so that's kind of how we're integrating this idea and how it's playing out.
Are you seeing a lot of impact from those personal testimonies?
Yes. Yeah. Immense. Yeah. And it's great. We're seeing the bad bills nixed, and and then the good bills are going through to committee. So it's been a ride so far, but I think overall, they've been very helpful and impactful.
Hey, before you ask your question, let me just make a point here. That is, health and all is really challenging. It's challenging because the people like Alexis who work in public health are powerless to change what other agencies do and what other agencies set as their priorities. That has to come from within. That has to come from within them. So you can talk to them, you can plead with them, you can show them data and so forth and so on. But ultimately, a lot of times they're more concerned with fire protection, let's say, than they are with this. So it's an uphill struggle, but it's an important one because go back to that chart that she showed you. All the connections are there with health and all the things that other people do, other organizations do. So it's really important to get that on board, but it's a hard uphill struggle.
It is. And I think when it's community driven, that's where we see the most success. And our associations are representative of the community. And we do have members of the community coming in and testifying even. So that's sort of where our efforts are. And Peter makes a great point. Agency to agency is a struggle. But if we sort of build it from the ground up, from the community up, and have them as the drivers, then we're a lot more successful in these things.
I was curious about the cross-jurisdictional sharing of services and also the multi-sectoral collaboration, just because I feel like that could personally be helpful to a project I'm doing in this class.
Oh, okay.
Would you like to elaborate on those two little bullet points just a little bit?
Yeah, sure. So multi-sectoral collaboration. What would be helpful, I guess? An example or just some information?
Essentially, I'm trying to reduce the flow, like the fatal flow of health workers from lower income countries. And I was curious about the multi-sectoral collaboration as well as the cross-jurisdictional sharing of these services, because to me just that sounds like that trend is that we are sharing our public health services or workforce a little bit more, and maybe that's not a bad thing is kind of what
Right. Yeah, you're absolutely right.
So I just wanted to get a little bit more about like what.
Sure. So I can give you an example from the state. I mean, we have health departments who actually share resources. So I don't know if you all are familiar with Riverstone Health, but they're experts at this. I mean, they're cross-jurisdictional in and of it. You know, it's like they're the definition. Because they share resources, they share services. People from each county can go to the other and they work together. I mean, they can even transition to different offices and work from different offices. They share data. That's one of the most important, is the data sharing. And that's happening. I think the multi-sectoral collaboration, that's where we're seeing slower, like at a state level, like very, very slow progress. We're moving that way, so it's going to happen. And we see from our funding sources that grants are requiring this more. So it's sort of like forcing us to do it, and it's not a bad thing. I mean, we're able to share, like there are so many times, and I can't tell you how many times, duplicative efforts and duplicative programs. And it's just like, what a waste. I mean, if we just combine efforts. So I think that's happening more. It's just slowly. It's very slowly. But if you want additional resources, I can point you in the right direction. So just send me an email.
Okay, time for one last question.
Yep.
Okay. I had a question on the same topic, actually. I was wondering, what you think are the best strategies or approaches for doing cross-jurisdictional sharing and multi-sectoral collaboration, because you mentioned a lot of siloing is a really big problem, especially in Montana. And I've seen a couple projects that are kind of addressing that, like addressing homelessness, like the Fuse project. And I was just wondering, what have you seen that seems to work the best?
Well, I think it takes leadership who sort of have this drive so it has to. Especially at the state level, it has to come from above. We're very limited on that. But I think where we do have a little bit more control is in our coalitions and our committees and our work groups. And so that's where you see a lot of that crossover, to sort of just communicate and say, hey, this is what's going. It's not even necessarily like, let's work on this project together. It's just communicating. This is what we're doing, and talking about mutual benefit and those kinds of things. So I think where you see the most, the most success in that is in those work groups, in those coalitions and committees, where we do have a little bit more flexibility and control.
When you say it has to come from above, what does that mean exactly?
Sort of like, from just like in government, from your from your big boss. Like,
we're going to do this now.
Right. So that's like an easy way to get something done, right? But you can also drive it from below with your coalitions, with your work groups and stuff like that. You can sort of change attitudes and direction that way as well. I mean, it's a ton easier when you have a boss who's like, feel really strongly about this, it's super important, let's do this. But yeah, you get the movement really within those smaller groups. So
I think that, Jill, I think you've raised a really good example when you mentioned homelessness, because I think that Missoula has really made some great strides in this direction. And they do have active groups of people who meet frequently, who are composed of people from refugee resettlement agencies, composed of people who deal with public health in this community, people who are working for the city, law enforcement people. And they all work together, and they've come up with some really amazing strategies and plans for how to, and of course, let me not forget NGOs like the Poverello Center and other places like that. And they've come up with plans for how they are going to accept and work with people who are recognized as perennially homeless. So they have almost like a quota system of sorts. And so this kind of model, which is really, I think, taken off in the area of homelessness, would be a very interesting model to take into the public health sphere. I don't think it's happening there. It's not happening. It's on paper that if there was an emergency they could do that, but I don't think they're having the kind of frequent interaction at the local level in public health that we see in the area of homelessness.
You're right. Yeah, and I think, yeah, that's a great point. And I would echo that. I think to kind of go back to just what you were talking about too, I think, don't be discouraged by what I said about, just leadership. We are the drivers too, right? So we can take the wheel and say, I want to take on this project and do it, right? I mean, there have been so many strides that we've made in public health workforce development just because I said, I'm doing it. We're doing it. Let's go. And just pulling, and Peter and I talked about this earlier, relationship building is huge. It's huge, and it is so helpful. If you know somebody and you're able to say, hey, bud, I really want to work on this project. What do you think? Is this something you'd be willing to help me with? And it's wild how effective just being a person and a human and a friend, can be. So I want to wrap it up here. Let me see. I think my mouse might be dead here. So again, where you fit in all this? I just wanted to provide a couple, simple takeaways. Since you guys are getting ready, gearing up to enter the workforce, keep in mind there are so many different opportunities in public health, right? So many different professions within public health. So many different jobs. Like we have at the state, for example, we've got health educators, doctors and nurses, sanitarians, epidemiologists, emergency preparedness planners, and people like me who do workforce development, right? There's so many opportunities there. The other thing is, I mentioned skills gaps throughout my presentation. Do you fill any of those? If not, fill them, right? Do what you do best and do the research. See where you might be able to develop your skills and fill those gaps, especially technical skills, right? Core competencies, I mentioned that earlier. Take a look at those. See where you stand and use research as leverage for you moving forward and getting where you want to be in your career. And develop those skills that are needed by public health based on your area of expertise, based on your interests and where you want to work. Use all of those things as leverage. Do your research. I know, it took me a while to find my place, and I think we all, have to go through that experience and that journey in some way, shape, or form. But there are ways that you can, entering into the public health workforce, really leverage what you've got and what skills you have. So those are just kind of my words of wisdom and guidance. Here's my info. Give me a call. Send me an email if you have any questions. And thank you guys so much for having me. It's been a blast.
Thank you so much.